Thank you for that kind introduction, and this invitation to present this distinguished lecture is both an honor and a pleasure, and I'm happy to see this large audience here today, and also so many young people who might not have experienced osteoarthritis. So perhaps if we can solve the problem, you might never get to experience it, which is really our hope. I've titled this lecture as a question, and it's a question I've asked almost 40 years now in my research, and we still don't have a good answer to this question, and I hope today someone will give me that answer from this group. But I'll pose the question. So, because we don't have a solution, here's a common question that's asked by a lot of patients when they go to see the doctor, and a statement. And the common response for most physicians, who can tell me? What do they say? Doctor, it hurts when I do this?
Don't do it.
Wrong answer. And this cartoon, it was attempted being humorous, but it's an attempt to really give the essence of my message here. Here's what I think the answer of the future will be. and that I'm glad you laughed, because there's a double meaning to this, and it's really to talk about the interaction between the mechanics of movement and biology, which I really think it will help answer this question in the future about why haven't we got a treatment, and perhaps can we find a treatment. So that's the message here. The rest of this is going to be fluff after this. So really, the message here is really the interaction between mechanics, biology, and actually structure as well. And the other underlying message is really we need to change our thinking about osteoarthritis. And we've kind of thought about it within disciplines, like the biologists think about it in one way, the biomechanicians think about it another way, the MRI imaging specialists think in another way. And if you talk to them individually, they all are convinced they have a solution, but when you take a step back and actually look at the patient, we don't have a solution yet. So what I'm advocating for in this presentation is that we take another way of looking at osteoarthritis. And it's really within an interdisciplinary framework, and perhaps one that's just emerging. And the group here at Cardiff, I think, is one of the leading groups that is taking this approach. So just for those not familiar specifically with what osteoarthritis is, it's different than just arthritis, where it can contain some of the features of arthritis. Arthritis is just merely an inflammation or a stiffness or warmness of a joint. And there's probably more than 100 different pathways to have an inflamed or what's called an arthritic joint. Also, there's other classification. Rheumatoid arthritis, which is an autoimmune disease, which is associated with inflammation as well, is not what I'm going to be talking about today. Really, the issue is osteoarthritis. And what causes it? How can we stop it? How can we treat it? Now, a few years ago, Time magazine talked about the coming epidemic of arthritis. Really, what they meant was osteoarthritis. And what they were looking at were all the big risk factors that were getting bigger. Aging. We have an aging population. One of the primary risk factors for osteoarthritis is aging, because osteoarthritis is a wear and tear of the joint and a breakdown of the joint for mechanical reasons, but other reasons as well. Obesity is another big risk factor. Trauma, an injury to one of the major ligaments or the meniscus, is a significant risk factor. Joint instability, whether congenital or acquired, is a risk factor. If you put all these together, osteoarthritis is a significant health problem that has social impact. It causes, in its end stage, major disability, and it has a major economic impact because it keeps people from being able to work. The Center for Disease Control in the United States predicted by 2020 there'll be 40 to 60 million people that have clinical forms of arthritis. What I'm going to suggest as part of this lecture that there are more than that have the disease but don't know they have the disease as yet. So most of what I'm going to talk about today is related to knee osteoarthritis, because it's one of the most common forms. And on your left, you see what looks like a healthy knee. If you've just flexed your knee and looked straight at your knee, you'd see shiny, healthy cartilage if you don't have osteoarthritis. On the other end of the spectrum, if you're ready for a total knee replacement, it's what we call end-stage disease. All of the cartilage is gone, and it's in all cases, that would be a painful joint to move, and you'd probably be wheelchair-bound if you had that severe of a disease. Now, what are the treatments? Well, pain. You take medications, anti-inflammatories, you'll take analgesics at the very early stage in the disease, and so there's a lot of medications that work. As it gets more severe, there's load-modifying interventions. Even surgically, there's a procedure called a high tibial osteotomy, which is just cutting of the bone to realign the joint and change the mechanical stress distribution away from the part of the joint where there's disease present. It's kind of like realigning your tires if one side is out of alignment. As you get towards the end stage of the disease over here, there's really nothing except a total joint replacement that will work. And that's probably the most common and frequent approach to treating the disease, but not really treating the disease. It treats the symptom of the disease. So none of these really treat the disease. Just a word on total knee replacement. It's been very successful, and I've worked in this area myself, and it's been very satisfying, but it treats end-stage disease. And what's happening now is we have an aging population that's actually more healthy. People in their 60s and 70s want to still run, play tennis, go skiing. I happen to be in that category myself. And we want something other than a joint that limits our range of motion and our function. So, one of the things that we have to ask ourselves as researchers in this field, what are the barriers? What's stopping us from finding these treatments that will enable the disease to be slowed in its course or perhaps prevented in the future? Well, if you take a step back and look at the pathway to osteoarthritis, again using this same paradigm, you see that in the very early stages, it's very difficult to detect the disease. This is probably part of the holy grail of why we don't have a treatment. I would guess that a percentage of you over 40 in this room, if there are anybody over 40, have osteoarthritis and don't know it yet. Your joint is starting to change. If we took an MRI and we looked at some other structural features of your cartilage, it would look like an osteoarthritic cartilage, even though you don't have it. Now, the disease will progress, but it progresses at a slow rate, and it progresses at different rates in different individuals. So this also makes it difficult to decide when to initiate treatment. It's hard to detect, and the rate of progression it varies among individuals. And what's even a bigger problem is it's difficult to detect the response to treatment. One of the big barriers to developing disease-modifying medication now is a length of time and the number of subjects it takes to show a statistically significant clinical effect of a treatment. So most of the pharmaceutical companies have abandoned developing disease-modifying medication for osteoarthritis because of the cost of the clinical trial. A few years ago, we were working with Pfizer, and they abandoned developing disease-modifying pharmaceuticals because they were talking about estimates in dollars of $600 million to $1 billion for a clinical trial that would prove efficacy beyond current types of treatment. And really, one of the reasons for this is the current gold standard that's really the method for detecting treatment is still radiographic assessment, which is fairly crude. Here's just a radiograph of a knee with some early stage changes, and there's end stage changes. But to detect a response using that kind of technology, and this is what the FDA in the United States requires, is it takes years and years to show a detectable effect here. And the other method is looking at pain response. Pain response has a lot of inter-individual variations, and as a result, you're all over the place. We have seen knees of people where we have MRI with very severe cartilage defects, yet no response to pain. or no pain response. And we've seen the opposite. People with constant chronic pain related to their joint, and on an MRI and on imaging, we don't see any defects in the cartilage. So the current methods, pain assessment, self-reported pain, and radiographic assessment are really not sufficient to allow us to take the next step. And so really we need to look for new methods in those areas. And the disease is much more complex than a single discipline can address. It's not purely mechanics, it's not purely biology, it's not purely joint structure, and we're not going to find a solution in one area. I'm fairly convinced of that. We need to see how those areas interact in a much different way than we have in the past. And so we need to address that complexity. Now, that's interesting. You know, for me, that's both a challenge and an opportunity, because if we can go beyond the current thinking, there are chances to take the next kinds of steps. So how do we address this complexity? Well, my answer is ask the expert. Who do you think is the expert? Anybody? The world's expert on? It's the patient. There's a lot of information that can be obtained by analyzing various aspects of patient function, patient biology, and patient structure. And if we do it in a systematic way, I'm suggesting that really that's the approach. This happens to be a patient that we tested in the 1970s when we were looking at total knee replacement using very old technology at Rush University in Chicago. But if we look at that, what the patient does is it integrates all these systems. By looking at the patient, we have now a systems view of what's going on with osteoarthritis. And walking, in my opinion, is one of the fundamental activities that we need to understand in the context of both the initiation and progression of osteoarthritis. It's the most frequent activity, and it puts substantial stress, in particular on the knee joint, which is an area where the osteoarthritis progresses and it can be the most disabling. Now, the knee joint is one of my favorite joints, and if you know my research, I've studied it for years. It's an elegant mechanical design. It allows for transmitting of high loads. During walking, you'll generate 3 to 5 times your body weight across the knee joint on every single step. And an average person, even with aging and some degree of osteoarthritis, will walk about 2 million steps a year. So if you think of that in terms of stressing a mechanical system, you have cyclic load and high load over a range of movement. So this joint is very interesting. Here's just one of my favorite animations of how the knee works, and you can see the interactions of ligaments and the articulating surfaces allowing for complex movement. But because of its complexity, this joint is subject to a lot of problems. It's a frequent site of disease and injury. So it's a great joint, but it really gets injured a lot, which begs for me the question, or also the incidence of the knee joint in osteoarthritis is shown here. On the vertical axis is incidence of OA, and then age group along here. And as you can see, the incidence begins in the age range, if you can see the numbers along the bottom, about 40 to 45, just incidence of clinical osteoarthritis begins to emerge. And the colored lines are the knee for the male and the female, and as you can see, the knee begins to pass up hand and knee osteoarthritis, or hip and knee osteoarthritis, substantially in that age range, where females have a higher incidence as you get older in terms of knee osteoarthritis. So that's the at-risk group, with the knee really the most at risk of the major joints. So this begs the question in my mind about what's a nice knee like you doing in a joint like this? So if you're part of the engineering group, this is the title of my lecture for the engineering group tomorrow. So I'm going to go into knee mechanics. So if you're interested, come to the engineering lecture, wherever that is and whatever that is, tomorrow. So walking mechanics. If you're walking normally and your biology is normal, you're actually in a state of homeostasis between the mechanical loads that are generated when you walk and the biology and the structure of your joint. But if something happens, like trauma, you get old, obesity, all of a sudden you get a degrading joint, your gait will change. And I used a fairly extreme limp there. We don't need a gait lab to tell that person who's limping. At some point, along that yellow line, you would develop clinical symptoms. And then you're in a degraded pathway. Now, to put this into kind of schematic form, we described this framework in a paper in 2009, where in terms of maintaining healthy cartilage, there's a turnover always in your tissue, and it's maintained by the loads that you generate when walking. If you stop walking, you'll lose cartilage. If you walk too much or get overstress your cartilage or change the way cartilage stress, you'll start to lose it. But the repetitive loads that you generate with healthy cartilage maintain the healthy cartilage and actually can make it even healthier. Now what happens though, there's some period where things change. It could be with aging, it could be after joint trauma, it could be after putting on weight and or biological change happens associated with weight increase. And you go into this transition phase where now walking is not as good for you. And the same repetitive loads that when your cartilage was healthy, if they're too high, will actually start to break down the cartilage. And the key is to find out where this transition is from a homeostasis condition for your cartilage to one where you're in this degradative pathway. And if you remember that early chart I showed where it's hard to detect early what's changing or progression, that yellow to red line can take many years before it's even detectable. So again, with healthy cartilage, walking and loading and number of cycles is good for you. For unhealthy cartilage, that same walking and loading can cause it to break down. And the key is to know when, and the key is to understand it and use that information. So one thing I really want to emphasize, and it's really important, it's one of the big barriers we have is that these symptoms remain quiet or silent for a long period of time. If we could detect them sooner, there are interventions that would work that could be fairly simple. If we could detect them sooner and we could detect changes related to them, there are treatments we could evaluate in a much more cost-effective way. But till we get to that point, we can't handle that. And it's really often the case that those pains in clinical OA don't happen till you're a long way down the pathway where there really is no other treatment besides getting a joint replacement. So as part of kind of developing this understanding of the treatment for osteoarthritis, it's good to understand what maintains healthy cartilage. So I've put this schematic together and kind of for years now been trying to develop this framework for interaction between all of the various disciplines that apply to understanding osteoarthritis. And I've kind of put them in little boxes here. At the top, because it's my favorite, I have gait. But biology is a factor, is shown over here, and both cell metabolism and inflammation. Inflammation is present even at low levels, even at early stages of osteoarthritis. In fact, one of the things that happens with obesity is you have elevated levels of certain what are called pro-inflammatory cytokines, which suggests that your body is systemically functioning at a higher level of inflammation just because you're obese. Structure, the alignment of the joint, the way the muscles function over on this side of the equation also factor into the disease. And each of these play a role. But what makes it more complicated is they all interact. So you change one and you just don't change it, you don't change it by itself. You could treat biology, you could introduce some biological treatment, but if gait is changed in a way that's not anticipated or could cause a problem, you could actually make the condition worse. And a simple example, treat pain. Pain goes away, you think, okay, that's great. Treat inflammation, inflammation goes away, that's great. But what happens when you do that, and we've done this, we've tested it for it, the load goes up on the joint when you treat one of those. And if you remember when I said once you have osteoarthritis, higher load causes you to go into that more rapid degradative cycle. Similarly, biological replacements like tissue engineered replacements. If they go into a joint that's poorly aligned and the joint is treated, say, with some kind of a cartilage replacement, it's like putting new tires on a car that's still out of alignment. The tires will wear out. Similar, a lot of the failure with some of these biological replacements is they haven't treated the mechanical malalignment as well. So how is this general? This is a very general framework, and I want to make it a little more specific. And again, I start with gait analysis, but so in terms of understanding joint structure, one way, and a very useful tool, is taking MRI images. And what's shown here is a three-dimensional thickness map derived from magnetic resonance imaging of articular cartilage. And then if you drill down a little bit deeper, you can look at cell morphology, you can look at collagen organization, and biomarkers. And really one of the key things, I think, that we need to find is an early marker that when you go for an annual physical exam, they draw blood. That's another marker that perhaps they look for in your blood that says, hey, this person's at risk for osteoarthritis. Maybe this is some early intervention. But these are all connected. And it's really the research at the interface between these that are going to solve some of the problems. And Joe, so just to illustrate, again, I'm going to talk first about healthy cartilage. Let's look at the interface between cartilage morphology or structure and gait mechanics. Again, we'll put it into this multidisciplinary framework. And what I'm going to show, and just some brief data here, is that your healthy cartilage is dependent on the way you walk. And we can actually relate your gait mechanics to the structure of your cartilage. And some of this is based on MRI imaging. This happens to be a three-dimensional thickness map. This is the femur, and it's color-coded so that thicker cartilage is in blue and green and thinner cartilage is in red. And if we look at that a little more carefully, and we've looked at now more than 150 healthy knees, you see some very characteristic common patterns of this distribution of thickness on the femur and the tibia. And if you look at them here, I've kind of outlined them. I don't know if they show up. Yeah, I guess you can see the blue areas there are thicker cartilage. But what's interesting is that, oops, if you look at those in relationship to gait mechanics, what comes out is you can relate features of healthy gait to that distribution of thicker cartilage. So there's a structural adaptation to the number of cycles you walk as well as the nature of the loading that you apply. And walking seems to be the critical function that determines this pattern. If you take that thickness pattern again and put the femur on top of the tibia, if you look at the thick areas on the femur related to those on the tibia, they match. And they match in that range of knee flexion where the knee is between about 0 and 30 degrees. That's the areas where the highest loads occur during walking. It's not during deep squatting, it's not during stair climbing, it's walking. So it's cycles and load that seem to be the factor that cause cartilage in healthy people to adapt. So it's thickest in the load-bearing areas, which is kind of a good thing. You want the thickest cartilage in the load-bearing areas. And people often ask me, should I jog? Should I walk faster? Should I walk a lot? What if I put more mechanical stress on my cartilage and I'm healthy? Well, the answer is really comes from studies like this. This is where we looked at loading on the knee during walking in terms of a specific measure that affects the medial to lateral load distribution, or the load on one part of the knee compared to the load on another part of the knee. And it's a measure called the adduction moment. And the critical thing to remember about this is it affects higher mechanical load on this part of the knee, which is the medial side of the knee, as opposed to this part of the knee. So we asked the question, okay, if that's the way we walk, how about people that put more load, healthy people that put more load, or people that put less load on this part of the knee versus that part of the knee? Now, if load is good for cartilage, you would see a positive response. And that's exactly what we saw here. This is the ratio of the thickness of the cartilage here to the cartilage here. as a function of how high that load is on the medial side. And for healthy knees, it increases. So if you walk and put more stress on that part of the knee, you have thicker, healthier cartilage. And so it's adapted positively, as shown here. So the medial compartment cartilage thickness increases as the adduction moment increases. So as the load increases, the cartilage thick, healthy knees. So if you look at a little bit closer the mechanics of walking, we all walk in a very repeatable way. And if there's no pain or other things happening, we walk in a way to minimize energy consumption. So we walk within a certain envelope, but that envelope allows us to put more or less stress on that part of the knee, but it's reproducible. So one of the key messages here is walk, and don't be afraid to load your cartilage if it's healthy, because it will continue. So you're young people that don't have any injuries, you're good to go. The other interesting thing is, if you look at a little more detail, this is a more detailed map of that cartilage distribution. It almost is like an individual fingerprint of the loading. And if we look in a little bit more detail about the kinematic changes between healthy individuals, we can relate where the knee is loaded for a particular individual to where that thickest region of cartilage is on the articular surfaces. That actually is important for conditions like after an ACL or a meniscectomy, because one of the things that happens is the contact between the femur and the tibia changes, and it moves away from areas like this to perhaps areas like this. Now, if you look at the biology under those areas, they're different. And so one of our working hypotheses is that shift, just due to a kinematic or a motion change after, say, an ACL injury, is enough to cause cartilage to go into that degradative cycle, because that region of cartilage can't adapt to the new mechanical environment it's seeing because of the mechanical stress. So all of this, as an engineer for years, I had a lot of theories. And this is an old friend of mine, Gunnar Andersen, a clinician. And we'd sit and talk about them. And he'd say, we got to put these to look at the clinical world. And so, rather than thinking pure theory, he told me, pay attention to clinical experience. So one of the first studies that was very enlightening for me was that you can't predict the clinical response purely from a mechanical analysis without testing the patient. And what that study is one of high tibial osteotomy. I think this group has looked at, some people in this group have looked at it a lot. What it is a treatment for what's called medial compartment osteoarthritis of the knee. That's that region here of the knee. And it's often associated with what looks like a bow-legged deformity, as shown here. It's called a varus deformity. And what's done to treat it is this procedure, and it's a biomechanical treatment where the limb is just realigned surgically. I mentioned it earlier in that slide showing the pathway to osteoarthritis. The theory is, and it makes sense, that you redistribute the forces. So you get the osteotomy, before the osteotomy you have this higher force here, and after the osteotomy it goes down. And it's worked pretty well over the years for a lot of people. And so one of the first things I said, I figured I can just do a mechanical analysis of the deformity, and we could predict who would do well with the osteotomy. Well, it turned out that that didn't work. And if you just do a simple, straightforward mechanical analysis, you can't predict who's going to do well and not do well based on the alignment change. So that was one of my first experiences saying you got to pay attention to what the patient says. And also, John Insel published an article which actually preceded my observations and kind of killed a lot of the use of this procedure in the United States. So then we looked at the adduction moment. Remember that load? And I thought for sure we'd see that it would be higher in these patients with the varus deformity than in healthy controls of the same age. And these were patients with fairly severe bow-legged deformity. And we also found that there was no difference. Those numbers are not statistically significant. But instead what we found, and this was after 6 to 10 years of follow-up, that there were really two groups of patients in the way they walked and the way they produced an adduction moment. there was this low group here that had, in spite of a varus deformity preoperatively, they had a low adduction moment, which at first would seem paradoxical till you looked at their overall mechanics of gait, and they developed an adaptive gait. Then there was the group that we thought was what it should be. They had the high load. And we didn't know what that meant at the time. But we'd follow these patients up to 6 years. These two studies in the Journal of Bone and Joint Surgery were follow-ups of these two patients groups. And what we found is that if we had treated only the patients that had that low load kind of gait preoperatively, they all had good or excellent results. And they were far better than the typical clinical outcome. However, this group did not. Only about 70% of those patients had good or excellent results. And based on clinical standards, comparing them to total knee arthroplasty, people said, well, if that's the kind of result I'm going to get, I'm going to do total knees rather than. And so, but by using gait analysis, one could predict who would do well with a high tibial osteotomy. Again, this relates to this different rates of progression from a mild disease as shown here to a severe disease as shown here. The gait can change that rate of progression. The person has the disease, but if you slow the rate of progression to where it's becoming severe and symptomatic, you've done a lot for that particular patient. So going back to this overall pathway, we've talked a bit about healthy cartilage. But I want to shift now and talk about when cartilage degrades and how we control what happens along this pathway. Cartilage, we probably already have osteoarthritis, but can we control some of the things along this pathway? So let's go back to the adduction moment. And if you remember earlier, I said that walking can affect degradation as well as healthy cartilage. This is that same paradigm here. And if we looked at that adduction moment now in knees that had osteoarthritis already, we found the opposite. If you remember, for healthy knees, that was a positive slope with load. This is a negative slope. That means the more load that these patients put on their knees, the more degradation of the cartilage, the thinner the cartilage got with time and with load. So in this case, the cartilage thickness decreased. One of the hallmarks for detecting osteoarthritis is thinning of the articular cartilage. So individual walking patterns are important, and interrelating these individual walking patterns to cartilage morphology is important as well. So what happens in a patient, and again, this is conceptual, but what seems to happen in patients with osteoarthritis is either some level of pain or inflammation causes some people to either have or adapt a pattern of locomotion that keeps the rate of progression fairly slow. And that's why you see in some people it takes a long time for the disease to progress. Others, it makes it worse, and it makes it worse faster. And those are the ones where you see the disease happen much more rapidly. The key is, can we shift them from one pattern to another? That would be a form of treatment that wouldn't treat necessarily the disease, but would slow the progression of the disease. And there's been a lot of attempts. There's been things, the osteotomy in a way changes the load. It changes a little bit the gait, but it changes the load. Can we do something less invasive? Well, what this suggests is we want to change the way people walk. And this is, when I first mentioned this to my students, I said, walk this way is a good way of describing it. What came to mind for them is Aerosmith. Is that what I see something like? The older people had another thing. Anyone, when they hear it say, anyone older that, when you hear walk this way, would it, maybe this movie wasn't so popular. Young Frankenstein? Remember Igor, the guy, this guy here? You know, and he would tell people when they came in, walk this way. So people walk like Igor. So tomorrow's lecture to the rehabilitation group is titled Walk This Way. So if you're going to come, so I'm advertising. I figure it's good. I love infomercials, so I think this is a good way to keep. So there are potential therapeutic interventions, and people have tried a lot of things, wedges and other ways of gait modification. Gait retraining can be effective. Gait feedback can be effective, as long as you have a good paradigm for understanding. Something we developed over a number of tries is a shoe that has, what's shown here, a variable stiffness. And when you step on it, I'll show you how it behaves. But what it does is it changes someone with a high adduction or a high load gait pattern to someone with a low load pattern. And the way the shoe works is when you step on it, one side compresses like this. So it forms like a dynamic wedge, but it's a very subtle. If you just stood in that shoe, you wouldn't feel anything. It's only when the loads of gait start to produce that kind of, so as you're walking, you're constantly getting this kind of a feeling, but you don't really feel it, but it produces a small enough stimulus. And the neuromuscular system is kind of like an amplifier. It takes that little stimulus and it will amplify it. And what it does is it will actually shift the upper body movement in a way that lowers that adduction moment at the knee joint. And we tested it and in a one-year trial. It was a double-blinded, placebo-controlled study where we gave it to patients that had osteoarthritis, and we had a control shoe that looked just like it but didn't have that variable stiffness in it. And we found that when we used a clinical scoring method, we had a significant difference in improvement in pain over 1 year in that group that had the shoe compared to the group that didn't have the shoe. And one of the things you have to be very careful with these kind of interventions, the placebo effect is tremendous. And so the control group had a significant reduction in pain, but it wasn't as big as this group. So you really have to control for the placebo effect in any kind of intervention like this. The more severe the intervention, the greater the placebo effect. The other interesting thing that's just beginning to emerge now is that we're seeing differences in the rate of cartilage change over a longer period of time in this group, and we're hoping to follow them on a longer basis as well. So it looks like with appropriate load modification, you can get some disease modification as well. You can get symptoms, for sure you can get symptom modification beyond the placebo effect. And the shoe is now available, and there's a stand out here where it's selling it when this lecture's over. So back to the different conditions that I think are really the challenge and the opportunity. It's really early detection and detecting response to a treatment that is critical. And I want to go back to this multi-scale framework. And we've talked a little bit now about how cartilage is conditioned to load based on the structure-gait relationship. If you look at the biological side, it's interesting. You can see a biological response to mechanical effect. And to me, this is our most recent and I think most exciting result, and I'm going to share it with you now. Going back to what the message here is that I think there is an interaction that we can explore between biomechanics and biology to a greater extent than we have to now. And what's needed is really what I call addressing the elephant in the room. And the elephant in the room is, as I hinted at earlier, is we all look at osteoarthritis kind of like the parable of the blind man touching the elephant. If you talk to a geneticist, they're going to say for sure it's all genetics. Talk to a gait person, I'm going to tell you it's all gait. You know, if you talk to cell biologist, they're going to say it's cell metabolism and so on. And it's probably not one of these. It's really a combination of all of these. But the problem, and I think the answer to the question of why we don't have treatment is that that's the way osteoarthritis has been looked at to now. And we really need to look at it in a different way. And I'm suggesting we put that elephant in a box and think about osteoarthritis in a way that we haven't thought about it before. And structurally, what I mean by that is to put this biology, gait mechanics, function, whatever you want to call it, and structure into a single box and treat it as a system. And the system is really that patient that I referred to earlier. And one of the ways that engineers and a lot of even biologists and others look at complex systems that they can't explain every single element or the interaction between every single element, they treat it as a system responding to a stimulus. And what you do is you bang on the system and you see how the system responds. That tells you a lot about the system. And here we can bang on it in certain ways. Say we have an intervention or we have an injury or some kind of a stimulus. We look at the biological response, we look at the gait response, and we look at the structural response, all to the same stimulus. That tells how the system behaves. And that really is a surrogate response for the potential clinical outcome. Now, if I go back to my old friend Gunnar Anderson, he'd say, well, that's a lot of theory. Show me what it means practically. So what we did is looked at creating a mechanical stimulus to a biological response, and then looking at the overall structural changes. And the biological marker we chose was something called COMP, which is cartilage oligomeric matrix protein. And the reason that was interesting for us is that it's kind of a mechanical link between the tissue and the cell. And it's kind of a signaler between what the mechanical environment that the cells, that the tissue sees or the joint sees, and the biological response of the cell. And so what we did is we did something fairly simple. We took patients with osteoarthritis, and we had them walk and we drew their serum, and we measured the concentration of this marker in serum. We call it COMP. And then we had them walk for 30 minutes. And we then drew serum again, and then we drew it for up to every half hour for 6 hours afterwards. Remember, this was an experiment, so we were still trying to see where we were seeing a response. What we found is that when we looked at the change in COMP, pre and post activity, and then we looked at around the 3.5 hour mark after the activity, the change between resting and 3.5 hour concentrations of COMP predicted cartilage changes after 5 years. So here's a biological marker you can draw from serum that by creating a mechanical stimulus, you can detect which patients are going to get more rapid thinning and potentially a clinical outcome. Here's some of the data. This was published in last year in Osteoarthritis and Cartilage. And this is, again, just looking at cartilage thickness changes as a function over 5 years. This is change in cartilage thickness over 5 years, and the change between resting levels of COMP and 3.5 hours after activity. One of the reasons 3.5 hours was important was that wasn't just diffusion out of the joint. It was related to a metabolic response that happened in the cartilage as well. So it's interesting. If we would have only taken resting levels of COMP, we wouldn't have seen this, because when we tested for resting levels of COMP, there was no change. So this suggests the possibility now, again, remember these interactions between disciplines. Here's a mechanical stimulus producing a biological response that predicted a 5-year structural change. It's kind of like an OA stress test. You go in, if you get a cardiac exam and they just check your EKG at resting, it doesn't show the same things you would see at, after a mechanical stress. Same kind of things can happen with this kind of test. So really, what we do is complete this circle between the mechanics, the biology, and the cartilage changes over time. And I think there's a potential, as we explore these kinds of things further, that we can produce these OA stress tests that will produce something that we couldn't see just by isolated biomarkers, couldn't see just by looking at cartilage structure, and couldn't see just by mechanical testing. This approach was just summarized in a recent Nature Reviews rheumatology article, so if anybody's interested, I suggest you look a little more at depth at that. So what's the bottom line? Communicate across disciplines. Think about the patient. The patient tells us a lot about what's going on. It gives us an integrated view. And gait analysis is very, I hope you're convinced that gait analysis is probably the most important thing in this. And if you're not convinced, here's somebody that might, anybody recognize, this is a bad picture. There's a young view of a, anybody recognize this guy? He was tested in our gait lab in Chicago in the early 80s. Did I hear Michael Jordan? Yeah. After we tested him, the Bulls won 6 NBA championships. If that doesn't convince you, that's it. So I want to thank all the people who did it. At my age, I don't have individual students, I have generations of students. And I have a lot of funding agencies to thank. And thank you for your attention.